I think we'll begin this webinar. I'd like to thank everyone for attending the seminar and welcome to this. I think it's a very important topic that we're discussing this morning, and we have two great speakers to bring us up to speed on the issue of clean air and health. So just a couple of housekeeping things before I introduce our speakers. Well, firstly, I'm Jane Hayworth. I'm also an associate investigator with the Centre for Safe Air, and it's my privilege to be chairing this seminar this morning. We will be recording the seminar and it will be available on the Centre for Safe Air website if you want to refer back to it at any time. The order of this morning will be Professor Negishi will speak first, and then Professor Jennings, and then we'll have an open discussion. So if you have any questions or any questions come to mind, please post them in the Q&A section as they come to you. And then at the discussion point, we'll have a look at those questions and have an open discussion. So we will hold the questions until after both speakers. So let me introduce our speakers this morning. So our first speaker is Professor Negishi. Professor Negishi is the Professor of Medicine and Head of Discipline at the Sydney Medical School Nepean, which is part of the University of Sydney. He's a current National Heart Foundation Future Leader Fellow and also an adjunct at the University of Tasmania. Professor Negishi has pursued his academic and clinical interests in cardiovascular disease in the US, Japan, and Australia, and he's very well placed to address this issue this morning of cleaner air and heart health. Our second speaker this morning will be Professor Jennings. Professor Jennings was was the previous director of the Baker Institute from 2001 till 2015. He's the life governor, or one of the life governors of this institute, and still attending as a cardiologist at the Baker clinics. He's also chief medical advisor for the Heart Foundation, and he has extensive experience, clinical and research experience in the prevention, pathophysiology and treatment of cardiovascular disease, as well as expertise in First Nation health policy, as well as health policy in general. So I think you'd agree with me that we're fortunate to have both speakers this morning to present on this issue. Before I hand over to Professor Negishi, I would like to acknowledge country. So we recognise the Aboriginal and Torres Strait Islander people as the sovereign traditional owners of Australia. We thank them for their continuing stewardship of this country, its lands, waters and skies, which protect the health and well-being of all Australians. We respectfully acknowledge their cultural and customary practices, and in particular pay respects to their ancestors, elders and future leaders. So thank you. I would like to hand over to Professor Negishi, if you'd like to share your slides. Thank you.
Thank you, Jane. Can you see my presentation?
Yes.
Great. Good morning, everyone. And thank you, Jane, for the kind introduction. My name is Negishi, and this is my disclosure. Thank you very much for the Heart Foundations for the generous support for our research activities. And then the topic of today is the effect of air pollution to the heart. But when we think about air pollution, always the first thing comes up our mind is the lungs. So then I would like to begin with which one is the more important or the bigger in the scale. So this is the data from the Europe about mortality. So every year about 800,000 excess deaths due to the ambient air pollution in Europe. if I draw your attention to the left up corner, 20% of them are from the respiratory conditions, lung cancer, COPD, pneumonia. On the contrary, 40% were from ischemic heart disease. If we add 8% at the bottom from stroke, about half of them are from cardiovascular disease. So this is important issue for our cardiovascular society. If we think about the numbers about air pollution and this from global perspective, and then there are couple of the estimations. One from GPT, it's 4.2 million deaths per year. And then from the another estimation about 9 million per year. And then if we remember that COVID told deaths up to yesterday's about 6.9 over 3.5 years, it's roughly about 2.3 million deaths per year. Then if it's, as you can see, it's larger annual deaths even before COVID era in the air pollution area. When we multiply by 40%, it's 1.7 to 3 million deaths per year. We know the global cardiovascular deaths is about 18 million, which resulted in the 10 to 20% of the cardiovascular deaths is attributable to the air pollution, which is too large to ignore from the cardiac society perspective. With that a bit of the cartoon for the PM or particulate matter sizes. So as you can see, this is a cartoon of the human hair. The blue ball is the size of PM10, which is the less than 10 microns in diameter. But if you can see the smaller red dots are surrounding the PM10 blue balls, they are PM2.5. On the right side panel, as you can see in the magnifier, there's a little red dots. That's the PM2.5 particles. So they are very, very small, even smaller than red blood cells or even bacteria. And then there are the wealth of evidence in the literature, and then they use these 3 zones based on the levels of the evidence. Zone 1, which is I'm going to talk with you today, it's well-characterized adverse cardiovascular event, which is all-cause mortality and cardiovascular death. And this is the data on the x-axis PM2.5 level, on the y-axis risks of mortality. There was an initial steep increase about 45 degrees from the point of 0. So this suggests there's no safety threshold. But more importantly, it seems like mimicking there's a ceiling effect. But if we add the data from the high concentration of PM areas, there's a further increase in the risks of the mortality. So there's a continuous increase as the air quality becomes worse in cardiovascular mortality. And we looked at a bit of data in Japan about 250,000 of the out-of-hospital cardiac arrest, and then correlate with the excess deaths. So in Japan, which as most of you know, it's an island country, lots of breeze from the oceans. So air quality is reasonably satisfying and less than the regulatory standard. However, we still see this statistically significant increase or excess deaths every 10 microgram per cubic meter increase in PM2.5 level, all-cause deaths and cardiac out-of-hospital cardiac arrest increases by 2%. So this is the still important issue for the all over the world, including the lower level of the concentration in PM2.5. So there are 3 main mechanisms in this summarized. The inflammation begins in the lungs or alveoli or bronchial levels, which increases or causes the autonomic nerve system imbalance, increase in the systemic nerve system, and then causing the lots of the downstream effect. Number 2 is the systemic inflammation spillover effect. So then inflammation happened in the lungs, go into the systemic circulation, and then series of adverse effects happening. And then sadly, these PM2.5 are small enough to directly travel into the bloodstreams, and then they are, attached to the plaques or atherosclerotic lesions, and then cause lots of the worsening of or acceleration of cardiovascular disease. And then down the line, this is a common pathway to the cardiology literature, damage to the endothelial layer, and then there was a decrease in enos activity, and reactive oxygen species increases, and then low-grade inflammation continues. As a consequence, lots of data found or reported the shortening of telomere length, which is associated with the human life expectancy. With that, we looked at some of the Australian data. So this is the data we looked at more than 600 asymptomatic Australian adult, mean age of 56. And then at that time, annual PM2.5 level was 6.9, which is very good. But as the PM2.5 levels increases, there are higher incidence of the calcium scoring in CT scan. This is a marker of the atherosclerosis in these Australian populations. And also, this is the data from the Korea. They looked at the more detailed imaging of the coronary arteries, heart arteries. What they found was in the heart artery plaques, the plaque becomes more and more higher risk plaque, and also the lots of the fibrofatty and necrotic core, which also suggesting a higher risk plaque. So there's a change in the plaque characteristics as well, which increases the risks of the heart attacks as well. So then as a consequence, we know the incidence of the myocardial infarction increases as PM2.5 levels increases. And this is a paper, meta-analysis published in JAMA 2012. So this is a bit of the summary of what I mentioned so far. Then on the y-axis, PM2.5 levels. On the x-axis, it's an age. 10, 20, 30, 40, 50, 60, 70, and 80 years old age. And at the level of the 5 micrograms per cubic meter, that's the WHO annual standards. If we were exposed to the higher levels of PM2.5, longer and longer period, as you can see at the bottom, the plaque progress gradually but continuously. And at certain day, there is a higher PM2 levels, even their average, it triggers the event and it causes like heart attack or stroke. So this is the current concept of the air pollution and heart attack and heart disease. Another was in genetic load the gun, like this, but environment pulls the trigger. That's the expression in this field of research. And we looked at when I was in Tasmania, we looked at the effect of the clean air, the opposite side, if we can see any threshold effect of it. On the left side panel, there was a linear relationship between PM2.5 level and heart failure instances in United States. They extrapolate 5.8 microgram per cubic meter would be the potential target based on the linear regression. But leveraging the beautiful air quality in Tasmania, we looked at the data of the incidence and compared with the air quality on the right panel. We observed above 3 microgram per cubic meter, there was a linear increase in the heart failure incidence in Tasmania. So this is that threshold we found, but 3 is very close to 0. So I think our data is consistent with there's no safety threshold in this arena. Then we all know the bad air quality is bad to our health, but the question is how can we achieve it? So there was an interesting data during COVID in the Northern Hemisphere, and also globally, we observed a somewhat interesting decline in incidences of the acute coronary syndrome, which is basically heart attack, by 30%. This is a very astonishing effect because we worked hard to reduce this, but we couldn't achieve it. And this happened during COVID. We thought this is avoidance behavior, patient avoiding to come to the hospital because of the higher risk to the exposure of the COVID. As a consequence, and in Italy, they observed increase in out-of-hospital cardiac arrest. However, out-of-hospital cardiac arrest does include non-cardiac causes. So we are not sure if it's from the heart or the other causes, even COVID. So we utilize the data of the New South Wales observations during COVID because we suppressed the event nicely, but we applied our lockdowns. As you can remember, on the x-axis, this is January 2020 to December 2020. Our first lockdown started on the 15th of March. And then as we see this color getting more thickened, we applied severe lockdowns. And then we lifted it gradually and completely and 1st of July. So this is what happened in the New South Wales. And then we looked at if any excess incidences of these events. On the top line here, it's a 0. So if anything from below this level, it was the decrease. So this is the entire acute coronary syndrome data. There was a significant decrease in the count of the ACS, and then the nadir at the strongest or severest lockdown. And then this is non-STEMI and also STEMIs. So all of them reduced during COVID period. And then surprisingly and importantly, out-of-hospital cardiac arrest during this period was also reduced. So there was no worsening in the out-of-hospital cardiac arrest. We changed the y-axis scale to the relative to the proportion, then roughly 30% reduction in ACS and non-STEMI and STEMIs, so as well as the out-of-hospital cardiac arrest. So what we found was there was no increase in the out-of-hospital cardiac arrest, which means the reduction in this ACS probably a true signal, not merely from the avoidance of behavior. So we looked further on this aspect, and then what we found was the air quality change. So blue one was the air quality PM2.5 levels from 2020, and the orange and brown ones were from 2018 and 2019. When we magnify this, as you can see, there was a steady reduction of PM2.5 level during this period and beyond. This was the China border closure, and then this is a total border closure during that period. And then these are the pictures from the Financial Times. This is a picture from India. They said for the first time in their life, they were able to see Himalayas from his town. And then, as you can remember, there was a significant improvement in air quality in China, as well as globally, and the United States as well. So actually, this is not the first time we see the sort of the improvement air quality with lockdowns. Back in 2016, there was a G20 summit in China. There was a reduction or improvement in the PM2.5 during the lockdown period. and there was a reduction in acute myocardial infarction. Similar things was observed in Beijing Olympic 2008, and also diesel emission reduction in Tokyo as well. So we were able, this is sort of things we thought before COVID back in 2018. We can do something, but it was difficult to implement. But if we can learn from something, from our sad experience from COVID, less flight, less traffic, work from home, stay home. If we can apply some of these measures, what we did during lockdown, we might be able to improve or reduce ACS or heart attack further. So with that, this is my take-home messages. PM 2.5 is the principal air pollutant posing the greatest threat to the global public health. The cardiovascular health consequences of air pollution generally equal or exceed those due to pulmonary disease and cancer combined. Overall evidence is consistent with the causal relationship between PM 2.5 and cardiovascular mortality and morbidity, which Professor Jennings will cover in a subsequent talk. As I mentioned, mechanisms are inflammation, oxidative stress, endothelial dysfunction, vasoconstriction, and autonomic nerve imbalance. Importantly, no safe threshold for lower concentration of PM 2.5. In the other side of the coins, even our air quality is satisfactory, any single drop in the PM 2.5 level can be translated into the improvement or reduction of the cardiovascular event. With that, air pollution, I strongly believe it is an important modifiable risk factor for cardiovascular disease. Thank you very much for attention. I will stop sharing here. Jane, you are muted.
Thank you very much for a really lovely and clear overview. So I'll hand over to Garry Jennings in the interest of time. So thank you, Garry, if you wouldn't mind sharing your screen.
Thank you very much, Jane. And I'd like to begin too by paying my respects to the traditional owners of the lands on which we speak in this very important week, and say how delighted the Heart Foundation is to participate with the Clean Air Centre on this important issue, and one which anybody that's following the international literature will know is increasingly important in everybody's minds as far as cardiovascular risk prevention is concerned. Just waiting for my slide to change, and it's going to do that. Sure. I'm sorry, this has gone to sleep. These are my disclosures. And moving on, as you've already heard, there have been countless analyses of excess deaths associated with air pollution, and cardiovascular disease is really one of the most important, indeed, as Kaz has already explained to you, the most important. And this shows the distributions around the world. And I show this slide because we tend to think of air pollution as something that happens elsewhere. But clearly this is something that COVID has exemplified with the data you've just seen, that is affecting Australia too. Most of the loss of life expectancy is in low and middle income countries, but this is something which there is certainly an inequitable distribution. Firstly, it affects, as you can see on the right, the very young and the very old, although it has consequences at every stage of life. You can see that the distribution around the world is very different to that other great pollutant, tobacco smoking. And you can see in the bottom right-hand panel, as Kaz has already shown you, that ischemic heart disease is indeed the major health consequence of air pollution. Now, these are the guidelines and thresholds from around the world, and I'd point particularly to the WHO, which have really taken on board the point that has already been made that there may be no safe level of air pollution, because they've really become much more stringent as far as their predictions, as far as their recommendations are concerned. And as you can see, the 2021 recommendation of a limit of 5 micrograms per metre cubed for PM 2.5 is indeed below the Australian average for PM 2.5. So this is something that affects us, and it affects us in different ways, of course, depending on whether it's gaseous pollution, particulate pollution. You can see all the candidates are there, and these will be variable according to the circumstances, the location, and the cause of the pollution. Now, this is an excellent document, which I'd recommend to you all, and you're going to hear about it a little bit more later in this webinar from the Centre for Safe Air. And it does point out all of the associations that have been reported in the scientific literature with air pollution. And we're going to be talking mostly today. We've already heard about cardiovascular mortality and morbidity. We're going to be talking about cardiac arrest and hypertension. You've heard a little bit about heart failure, arrhythmias on the list too. And then we have stroke, we have disorders of coagulation, we have things associated with pregnancy, which are predecessors of subsequent cardiovascular disease later in life. So cardiovascular disease is popping up all over the place as far as consequences. Now, studying this as I think Kaz has emphasised, is a difficult thing, and we've been, very unfortunate to have a COVID pandemic, but it's been very beneficial as far as a natural experiment is concerned, and our ability to tease apart some of the things that we know go along with air pollution. Of course, I've mentioned the different types of pollution. We know with long-term cohort studies of this that people are aging as well, and that could be contributing. We've talked about socioeconomic disadvantage, which is associated with air pollution, but of course lots of other things go along with socioeconomic disadvantage as well as living in potentially polluted areas. There's good literature to show that in polluted areas, people aren't as physically active. They don't go out into the dirty air as much. And then there are, of course, different ways of measuring it. But in summary, what we see is that short-term high-dose exposure to air pollution tends to worsen existing conditions. That is, it affects the vulnerable most. It affects people with heart failure, particularly. Affects people with a pre-existing cardiovascular disease, and it may well precipitate an event. It may turn a plaque, which you've just had described very clearly to you, from a silent clinical manifestation of atherosclerosis into sudden death or an acute myocardial infarction or one of the other catastrophic consequences such as stroke. Long-term moderate exposure probably influences the onset or the progression of the disease, and I think you saw some nice data from that as far as coronary calcium screening is concerned. Now, looking at the various cardiovascular manifestations associated with cardiovascular disease, there have been many studies in many populations using, as this column shows, many different patterns of pollution, and they all point to different cardiovascular associations. And perhaps one that just comes through over and over again is hypertension, which of course is a major risk factor for coronary disease. You heard a bit about acute coronary syndromes. There have been some clear reports about higher rates of arrhythmias, including atrial fibrillation, an important cause of stroke. Heard a little bit about death and the autonomic changes, and there are clear associations with thrombosis and coagulation, a few studies as far as lipids are concerned. So it seems that you don't have to look far to explain why air pollution might be associated with more cardiovascular disease. We've already talked about the mechanisms that might be involved in acute coronary syndromes and myocardial infarction. They're really very similar. You can retrofit a very plausible explanation for why hypertension might be more common as far as inflammation, autonomic and sorry about that, and other things are concerned. For example, we see autonomic imbalance, we see endothelial activation, platelet activation, we see systematic inflammation, we see atherosclerotic pathways. And all of these are associated with changes in the vasculature. And remembering that every drop of blood which passes out of the circulation is already passed through the lungs as well. Diabetes and air pollution has been associated, a strong association too. There have been studies relating impaired glucose tolerance to air pollution, insulin resistance, another feature of type 2 diabetes, as well as, of course, type 2 diabetes incidence and prevalence. And these associations seem to vary by the length and the type of exposure. And again, there have been numerous epidemiological studies in very many populations. Now, we shouldn't miss a chance to promote a study from Australia, which has made the front cover of Nature, and this is in the last 2 weeks. And this is from the Monash Public Health Group. And they've talked about something which, of course, is very topical to us at the moment, and that's bushfires. And this is a different kind of pollution because it's intermittent. And in one way that allows us to study it a little bit better. This study reported that landscape fires contributed about 4% of our total annual exposure to ozone and 6% of total exposure to particulate matter, particularly to 2.5 or PM 2.5. So again, this is something particularly relevant to Australia. We tend to think of it that way anyway, even though this global distribution suggests that it's something happening all over the world to a greater or lesser extent, and again to a greater extent where in places where other forms of pollution, the more long-standing chronic forms of pollution related to industry and other things are happening as well. But this shows the trends are increasing in many parts of the world, including parts of Australia. The thing about bushfire pollution, as I said, is it is intermittent, and this is just a little snapshot from that paper of Oceania, largely driven by the Australian experience. And it just shows that at different times and different years, the relative proportions of gaseous pollution compared to PM 2.5 varies. And that might explain different patterns of disease and different levels of exposure. There's been a little bit of work again using some Australian experience related to a point Kaz made earlier, and that's where the cardiac arrests are associated with PM 2.5. And going back to earlier in this century, it was suggested that in a particular period of 12 days of forest fire smoke in Melbourne, it accounted for some 24 extra out of hospital cardiac arrests, which seemed to be explained by elevations in PM 2.5. I'm going to move now a little bit to a different subject, and that's noise pollution. And these are levels of exposure to noise that we experience with construction, passing trains, light traffic, heavy traffic, all in the order of 80 to 100 decibels. That's enough to stop frogs croaking. And when frogs don't croak, their reproduction stops or reduces. It's enough to make wild birds seek quiet areas, and they'll stay away from noisy areas. And that's vital to seed dispersal and tree growth. So I don't have to tell you that the consequences of pollution, including noise pollution, goes far beyond human health and far beyond coronary artery disease. But it does affect human health. These are different studies, again using the experiment, the natural experiment of COVID, when aircraft noise was diminished with airlines not flying, and this shows things that are closely associated to the development of hypertension. In this case, the ability of the forearm vascular vessels to dilate, and we know that with it's a measure of endothelial function, which is not only associated with hypertension, but also an early feature of atherosclerosis. And with increased noise exposure, there's a diminished endothelial function. Nighttime, in particular, noise exposure was associated with reduction in the ability of the vessels to dilate properly, and you can see oxidative stress markers also increasing. And I guess it's not surprising that at least with noise exposure as opposed to air pollution, nighttime is the time when people actually feel it most and feel the worst. And this is showing you effects on vascular stiffness and on rates of hypertension. Again, it's not that difficult to come up with a plausible explanation as to why this might occur. And again, it comes through those changes that I've just shown you in endothelial function and the normal homeostasis of vascular function, which gets disturbed under these conditions. So as I've said, and as you've already heard, air and noise pollution have got very strong associations with cardiovascular disease mortality and morbidity. And despite the fact that there are potentially lots of confounders, there are very plausible mechanisms through which acute effects in vulnerable people and through hypertension in the longer term might lead us to greater rates of cardiovascular disease have been observed in these major epidemiological studies. And it's quite likely that inflammation and oxidative stress are very important mediators, although there may be others. Thank you very much.
Thank you, Garry, and again, a very nice complementary presentation, particularly focusing on some of those high pollution events such as landscape fires and bringing in the issue of noise, which I was very pleased to hear you do, so thank you. I have a couple of questions, but I see that there is a question on the Q&A, so I'll start with that from Arabella Danielle from Clean Air Communities. And her question is, we know that solid fuel combustion, wood heating, is a significant contributor to PM2.5. The Heart Foundation website simply advises to avoid indoor fires for cooking and warmth. Can we encourage the Heart Foundation to provide more comprehensive health information on the hazards and more pressing advice to switch to cleaner alternatives?
Absolutely.
Yep, go ahead, Garry. Thank you.
It's probably my problem, the Heart Foundation statement. Yeah, absolutely. As I said in the beginning, the evidence is just getting stronger and stronger as far as PM2.5 in particular. Of course, there's more evidence for PM2.5 than for other forms of pollution. I wouldn't exclude the possibility that more might emerge for other forms as well. But we take that point. I mean, that present recommendation, of course, comes mostly from indoor cooking, which is such a problem in low and middle income in certain low and middle income countries. But I think as the evidence emerges, the Heart Foundation is very likely to become broader in its consideration.
Could I ask a follow-up question to Garry? So,
yes, please.
So then as you mentioned clearly, we are getting more and more aware of these issues, but it's not the majority of the cardiology practitioners or the medical practitioners aware of it. What would be your recommended way to increase awareness of it? And we should increase more sessions at the conference, or as you mentioned, we can get some a great help from Heart Foundation or similar, the foundation body to help us to enlighten the public people or other people?
Yeah, of course, a lot of the solutions lie at the system level. So it's really about, it's not so much what the individual practitioner can do, it's what the system can do, and that's and that's not just one government department either. We need a whole of government response to this too. I do think that there's been a sense that this is something that affects other places, not here. And I think that we need to do, as we're doing today, a little bit more of making influencers aware that this is something that's affecting us here now, and having consequences not just on human health, but on health budgets and on deaths and disabilities. So the case is there. I think it's getting stronger and stronger. We just need to make sure we put it in the right places.
Great, thank you.
I have a related question, but whilst I provide that question and answers from the panelists, I just want to encourage people to add some questions to the Q&A from the audience as well. But just related to the previous question, and Kaz, your comment about that we can see clearly benefits during COVID where air pollution was reduced. How do we approach our car dependence in cities? I think you've also identified traffic as a source of PM 2.5, and yet most of our cities are very car dependent and spend a lot of infrastructure on widening roads and etc., which has issues, of course, in terms of exposure differing across socioeconomic class. So I wondered if you two had any comments on that.
Great. Thanks very much for the question, Jane. We believe it's a multifactorial effect of entire behavior changes from lockdown. And then the key part is air pollution, but it doesn't cover everything. But as you mentioned, if we look at the air quality perspective, individual motor vehicles, the exhaust is the most important ones. So what we are thinking now is if we could do some social experiment to, let's say, increase the toll fees on Wednesdays and Thursdays, and then make the public transportation free, then we might be able to shift the commuting behavior to the public transportations. Or some of the countries, cities like London, they did the ban of these private vehicles to the city. Only public transportation or taxis can drive in the city. Then we might be able to see the signals. So this one, absolutely, we need help or support from policy makers, which I would love to learn how to approach them through the Professor Jennings. But these sort of Garry clearly mentioned, this is a system issue, the bigger issue beyond individuals. So we, as a researcher, continue to collect the convincing evidence, but we need to learn how to approach our policy makers and for better future of entire citizens.
Guys, how much do you see the move to electric cars assisting in this? And of course, it does depend on where the power comes from.
Absolutely, that's the never stopping discussion. But then if it's only we make it from the thermal, the power, it would struggle. But if we could utilize the beauty of this bigger land with wind or other things, we might be mitigate a bit. But there's a lot of the argument if it's truly the better or not. But I'm slightly inclined to the better side, but I'd like to wait for the end, more research on this. Would you have any views on it, Garry or Jane?
I think it's not just the absolute effect, it's also the changing psychology, the sense in the community that we need to do something about this, and that's something I as an individual can do. So I think irrespective of whether it's a big effect or a little effect, I think it's a good development, even though, of course, only at the moment they're expensive, and once again, only entitled people can really access that.
We have done some preliminary research on this area. Steve Vanderhorn has looked at this, and the effects at the moment are quite small, but I probably a bit inclined to agree that I'm on the side of electric vehicles, but I also don't think they're completely the answer, because it still allows essentially one person per car. And so much of our land, is taken up by car parks and freeways, highways, which could be really nice green space, which would also impact on people's health. So maybe that's a fairly naive overview, but I don't think electric vehicles are totally the answer, but certainly will reduce air pollution and some noise pollution. But just leading on from the noise pollution, Garry, there is a question in the Q&A. Firstly, thank you for the talks, but for noise pollution, does it have an effect on the body if the person is not feeling agitated or consciously stressed by the sound?
I believe those studies that looked at some of the physiological effects, yes, would suggest that it's not just a matter of getting anxious, and not anxious, but getting annoyed with the noise. In fact, of course, people tend to adapt when they're subject to a high noise environment, and people that sleep near airports, for example, tend to sleep all right, but they still have higher rates of hypertension.
Thank you, Garry.
I think all this is additive.
So, Garry, in terms of epidemiological studies, should we be including noise as a confounder with air pollution? Given that they coexist.
Yes, it will depend on the situation, but I think it's not hard to at face value, places that've got high levels of air pollution are often noisy places too. And I don't think it's very, or you can't in an epidemiological study tease apart the relative effects, but the things that reduce air pollution are quite likely to reduce noise as well.
There are a few more questions in the Q&A. What are the vulnerable groups in regard to noise pollution? Are infants and children more or less at risk than, say, adults?
Kaz might like to talk to this, but certainly there are consequences in pregnant women, which suggests that both pregnant women and people and babies in utero are potentially vulnerable. And there, without going into any great detail, there's a fair bit now emerging as far as long-term cardiovascular effects in adults. Might have partly a genesis in infancy and childhood. But the more common ones are older people with existing cardiovascular disease, things like heart failure, in particular, people who've suffered stroke, other forms of chronic disease, as well as those with diabetes and hypertension. It's probably the same list as we found with COVID, actually, that the people that are most vulnerable then are probably similarly exposed here. But Kaz might have some thoughts on that.
I echoed what Garry said, but certainly, for example, it affects in every generations. But then, for example, let's say firefighters, they work shift schedule, but also waken up by the alarms, and then these sort of things also affect. And in Australia, their life expectancies are similar or better than general population, but in United States, they die earlier because of various reasons. One is exposure to the air pollution. One is due to the unfavorable lifestyle, but also the alarms and noises So it puts further stress on this. But the firefighters assume to be they are healthier, the end of the individuals, and even they have it. And completely agree with the multiple hit theories. This is also the trigger the last event, but that's I think.
Thank you. There is a comment from Arabella, an important one. Just a comment on electric vehicles, that PM 2.5 from tyre and brake wear is a significant emission that wouldn't be eliminated by electrification. Of course, that's true. We have a question from Cass Rouse. What approach could be taken to factor in these risks for the burning conducted by forest fire management and similar organisations? Garry or Kaz, can I?
Yeah, I might take that. Thank you for the question. So then we did some studies actually in Victoria with the Professor Faye Johnston on this, because we are not sure about effect of plant burning on the the people dwelling there affected areas. We observed some changes, especially in the autonomic nerve disturbance in the Holter ECG. The heart rate variability was instantaneously within 5 minutes. It changes with the smoke exposure from the plant burning. So it does have the effect, but as we can remember in the Black Summer in the end of 2019, that has the huge impact on our health as well as economically, and it's our colleagues' phase work showed the about 2 billion excess the cost for entire society. So still we need plant burning, a sort of the fuel reduction burning, but the question is how we can do it minimally, or mitigating the adverse effect to the health. That's the question we have to continue to seek.
Thank you, Kaz. A question from Dorothy, which is probably more to the Centre for Safe Air, but would they be interested in providing estimates of the cost of various activities? For example, using a wood heater, cycling 5 kilometres a day instead of driving in different types of vehicles, for example, petrol, diesel, electric. These estimates could help inform public policy. I think that's a useful comment that we'll take on board at the Centre for Safe Air. I think this issue of influencing public policy is challenging because unless we have public support and public awareness that air pollution is an issue, it's difficult to get the policymakers on board. And also another comment about electric vehicles. We need to be careful that they don't cause another problem, for example, disposal of batteries on top of the associated fire risks from storage.
Yes, I don't think.
Go on, Garry, please.
Well, only that I don't think anyone should suggest that there are simple solutions here, that everything everything we do has consequences somewhere down the line, don't they?
And there's also a question here about vulnerable populations with regard to air quality. Have there been any specific studies on palliative care patients?
Oh,
Aware of any?
I'm not aware of that.
No.
To be honest.
I also am not aware. Garry, no.
No, I'm not. No, I'm not. I think you would imagine that they are, of all the vulnerable populations, they are about as vulnerable as you can possibly find. So.
Yeah. And at what concentration, this is another question, at what concentration and duration of exposure to PM 2.5 triggers cardiovascular health?
It's a sort of million-dollar question. So I frame this in this way. One aspect is long-term exposure. Even long-term, but exposure is the if we continuously expose, as I mentioned in my previous slide, and it increases or accelerate plaque progressions in the cardiovascular health. And then on the day there was higher, even higher, the PM2.5 exposure, it triggers the event. So we do not have any clear cutoff on this because of the linear or the continuous, even monotonous increase in the event. So it's hard to tell this because of multiple hit theory, but both short-term, long-term, they are very important aspect, and we have good evidence on it.
So essentially there are effects from acute exposure and chronic exposure.
Yes, and then it's hard to draw a line at certain level because it differs from patient to patient. And then, for example, if someone lived in the higher PM2.5 areas like China or India, and they get used to this level, their body is used to how to mitigate the effect. But if someone like us travel there, we will notice the huge jump in the exposure. It will trigger it. So both active aspects are important again, but we do not have any specific target for this.
Okay, well, I think it's been a really interesting discussion, and presentations have really provided a very nice summary of the impact of air pollution on health. And just some summary points to make is the importance of PM2.5 on the global burden of disease, and that, we're probably, our first thought is about respiratory health, but obviously the impact on cardiovascular disease is greater. And in terms of prevention, we're going to get more bang for our buck in terms of cardiovascular disease, but there will be other benefits, of course, on respiratory health and other health outcomes. And from the data that you presented, even though in Australia we have relatively low average concentrations of air pollution, although they are above the WHO standard, it would appear from some of the data that you've shown that there's the curve is steeper at lower concentrations. So we can't be complacent in Australia, even though with our blue skies and clean looking air, it's not necessarily clean. And maybe that's a message that we need to convey to the community. I think that, and so it's that acknowledgement that even at low concentration, we see health effects is important. And importantly, that whilst we present these average levels, that there are high risk events such as bushfires where the level of exposure is considerably higher. And even when we look at annual averages, in most of our cities, we see that the average of PM2.5 is far higher in winter than summer. So maybe annual average is not the best metric either. It would seem that there is no safe threshold for exposure. And one of the challenges for all of us is to try and influence public policy. We've seen very clearly this morning that if we reduce, we've certainly seen some evidence this morning that if we reduce air pollution, there seems to be concomitant reductions in cardiovascular health outcomes. So to focus on prevention through reducing exposure is definitely worthwhile. I want to thank the audience also for their questions and interest in this topic. But I did just want to also alert the audience to 10 reasons why we should be concerned with air pollution. Thank you, Bill. So I won't go through each of these in detail. They are on the Safe Air website under the Resources tab, but we can see the impacts of air pollution on both communicable and non-communicable diseases. It's affecting us from conception through to end of life. There are health inequalities in the impact of air quality. And we can also think about noise here as well. Noise is an important co-exposure. climate change and air pollution are interlinked. If we address air pollution, there are benefits across a very broad range of health and well-being outcomes. Over time, we're seeing as our cities grow, population increases, use of various, activities in traffic, etc., we're seeing that the impacts of air pollution are increasing. There's a gap, I think, in our knowledge. We know that the economic impacts of air pollution are high, but they're probably underestimated. Return for investment is high, even in Australia. If there is a steeper curve at lower concentrations, we actually get more bang for our buck by reducing air pollution here. And small improvements in air quality will drive large population health and economic benefits. So please have a look at the Centre for Safe Air website, read these in detail if you wish, and we're very happy to take on board people's comments and feedbacks, and thank you for your attendance this morning. A few more comments on the Q&A. I think they're probably mainly thank you, but if not, we'll try and answer them at another point in time. So thank you all again for your time this morning, and particularly to our two speakers, Professor Negishi and Professor Jennings. Very, very fruitful presentations. Thank you.
Thank you very much. Have a nice day.
Thank you.